To be here, and thank you so much, Dr. Kempo. So, and for everyone coming and learning about this. I was going to be a little bit of background about myself. I was going to be a foot surgeon since I was 7 years old, and so this has been a really crazy adventure for me for the last many years. I never imagined in my whole life being in a situation where I'd be here in Chile presenting any information to you. So this is a real pleasure for me. When I came into this whole arena of sinus tarsi implants, I knew about them for many years, but like everybody else in orthopedics and in surgery, we're always skeptical because, you know, we should be. We need to think about what we do for our patients because, especially with surgery, we're operating on them and we want to make sure we're doing the right thing. So I'm a podiatric surgeon in the US, and podiatry is, I don't know if you know the differences, but in the US we do all foot and ankle surgery. So usually in other countries, the podiatrist or podology is just doing trimming calluses or maybe using orthotics. But I wanted to be a foot surgeon, and to become an orthopedic foot and ankle surgeon, it takes much longer than podiatric. And I didn't want to learn about the knees, hips, shoulders, spine. I don't care about the spine. Who cares about the spine? So I only want to do foot and ankle. So that's why I became foot and ankle surgeon, podiatric foot and ankle surgeon. So one of the things that we learned so much about is custom orthotics for the shoes and how you can cure everything with this insert in your shoe. And I'm watching my patients that I'm making the best arch supports, and they're just collapsing. They're just walking right over this. And I said, this is not helping anybody. And I did the big rear foot reconstructive surgery, the lateral column lengthening, medial displacement, calcaneal osteotomy. And I said, okay, it's helpful, but there's complications. And you know, when the lecturers are on stage, they have amazing results, but they don't talk about the less than amazing results. So every procedure has potential complications. So one of my friends was telling me, well, why don't you put the insert into the sinus tarsi? And I said, I don't know, it just doesn't make any sense. But eventually I said, okay, let me try it. And so I put it in, and I was amazed. But then, like everybody else that puts these in, there was a high removal rate. And so I said, okay, there has to be a better way. There's something that's not right with these other implants. And that's what led to the birth of Hypercure. So again, and I'm not an engineer. I never in a million years thought that I would be inventing anything, but it's been really incredible. I want to say that no matter what surgery you perform, and if I'm talking too fast, please stop me down, because like Mario, I'm very passionate about this. But there's no procedure has 100% success rate. Okay, so even a below-knee amputation has complications, and that should be a pretty straightforward, complication-free surgery. But the good news with this procedure is that it really does no harm, and that's what we want for our patient. It helps way more many people than it hurts, and it doesn't really hurt anybody, but sometimes there's pain. So again, you know, when I first was thinking and using this implant, my indications were extremely narrow. But then I put it into a patient, and then the patient comes back and they say, wow, I had knee pain, but now my knee pain is gone. And I said, I don't care about your knee, how is your foot? And then another patient comes in and they say, I used to have back pain all the time and I was going to get adjustments, but ever since you put the implants into my feet, my back pain is gone. I said, I don't care about your back, how is your feet? But you know, we kind of get laser focused and forget about that the feet are the alignment to the body. And so, you know, little by little, this story has just really been exploded and where we can really help a lot of things. But I'm not going to stand here and say, if you know, we're going to cure back pain by putting in Hypercure. You know, we don't have those studies yet, but it just makes sense that and we have so much literature that says when your feet are misaligned, that it has a chain reaction to the rest of your body. And I just feel so sorry for so many people that are suffering with, you know, knee, hip, and back problems, and nobody ever took a look at their feet. Nobody ever said, okay, well, with every step that you take, your feet are twisting out, and it's twisting your knees. And that's why you have ACL ruptures and meniscal tears and all this trauma within your knee. And you have an athlete who's going to become a professional football player, but he gets hit the wrong way, and now his knee's blown out, and that's the end of his career. And you say, well, it's just a sports injury. Well, there's a reason why it happened, and because this kid has been running on hyperpronating feet that never hurt him, but with every step, like Mario said, we're twisting the knee and we're weakening the tissues. And again, it's the chain reaction of the body. Okay, let's get back to topic here. I'm getting off course. But the whole thing is, what happens when an artery closes? Do we have to go in and cut out all of the arteries of the heart and cut the veins out of the leg and put it in? Or can we just pop a little stent into the artery to open it up so that we have the blood flowing again? So when it comes to misaligned feet, we have to have the same kind of conservative approach. Before we go with the nuclear option, let's think about what the other options are. Now, the reason why I don't like to call this procedure arthroeresis is because arthroeresis has a really bad track record. It has a high removal rate. Patients have pain, and usually the device has to be removed. Plus, for patients, it's so complicated. Even for surgery, how do you say arthroeresis? How do you spell it? And how does a patient understand what this procedure is? That's why I like extra-osseous talotarsal stabilization. And I don't want to call this subtalar joint stabilization and limit it there, because we've just eliminated the talonavicular. And what makes the foot become flat is when the navicular drops. So we're helping all of the joints of the talotarsal joint, not just the subtalar joint. I'm going to skip through some of these because Mario eloquently talked about it, but there's a major difference of how we stabilize the talus on the calcaneus. And the difference is between a 60% retention rate versus a 90% retention rate. And if you pick the right patient, it goes even higher. And the whole point is that we want to follow the axis joint of the sinus tarsi. Now, we know about the sinus tarsi, but there is a function of the sinus tarsi that we never take into consideration. When we're walking, we land on the posterolateral part of our heel, and then the weight goes anteromedially. And so actually it goes posterolateral here and anteromedially. And the reason why there's an obliquity is because of how the forces are balanced and redirected posteriorly and anteriorly. So when we think about putting these stents in, we want to go along the natural course and orientation of the sinus tarsi. So with this stent, and the other thing too, I like to call it a stent, don't call it a screw, because a screw, that's very cheap and whatever, but a stent, hey, that sounds pretty good, right? So make it a little sexy for foot and ankle surgery, you know, it's like, yeah. So, but when we put this in, we have triplane correction, frontal plane, sagittal plane, and transverse plane. And we don't limit motion, and that's the problem with arthroeresis. It's a joint blocking, limiting. We don't want to limit motion, we want to restore motion. And so by putting in hypocure, we're restoring the motion. It's just like the hinge of a door. If the pin is not in there, then the hinges are off, and then when we put the pin in the hinge, now the door functions like it's supposed to. So it's really amazing. And once you do this, there's so many positive things that happen. So when we always think about what is etiology of traditional, like pediatric flat feet, we say, well, the spring ligament was weakened, or the plantar fascia is weakened, or the posterior tib with adult acquired flat foot. That's the problem. Well, what really caused all of those tissue deformations is because of the partially dislocating talus. So normally 48% of the weight should go anteriorly, but when we have a misaligned talotarsal joint, it increases to even up to 72%. And again, as Mario said, during the swing phase, the joints are aligned, and then when it goes into the stance phase, that's when the tissue trauma and the strain is occurring, and so the poor tissues have no chance. So we want to rebalance those forces, because for people with posterior tib dysfunction, plantar fasciitis and all of these other conditions. We can give them physiotherapy, we can give them injections, stem cells, all these fancy things, but they go right back to walking on that misaligned foot. And so what's the point? It's like taking your tire that has a slow leak in it to the gas station and you put air in it and you say, yes, I fixed the tire, look, it's nice and perfect again, but we never patched the hole. So of course it's just a matter of time before the tire goes flat again. So, you know, when you first look at these x-rays with the hypercure in there, you say, oh my God, how is this not going to cause a talus fracture, calcaneal fracture? How can people walk or function with this in their feet? Well, I've had hypercure into my feet for over 13 years. We have marathon runners, basketball players. We have, I don't even know how, we have probably over 100,000 procedures that have been performed, if not more. We have no fractures whatsoever. The talus, not a stress fracture, nothing like that whatsoever. And that's because the forces are acting on the facets. They're not, there's a very small force that actually acts onto the implant itself. So we're going to get into, you know, again, our correction and things later on, but this is something that you don't have to have faith and say, like with orthotics, you have faith. Well, yeah, we're going to put this in your shoe and yeah, it's probably going to work. But we don't have any radiographs to actually show how an arch support can realign and stabilize the talotarsal joint. But with this 15-minute procedure, we absolutely can show that. And the correction's instantaneous. I know we've seen this video a lot, but we can't, the pictures are just invaluable. I mean, this is literally about a week or so after surgery, and usually we like to do 1 foot at a time. Here's another one. This is, both feet were the same. And again, how can you tell the parents, oh, that's normal, don't worry, your kid's going to outgrow that. That will never, ever cause any issues to your child's body whatsoever. That doesn't make any sense. It's like driving with flat tires on your car saying, yeah, it's fine, don't worry. So there's so much literature saying, you know, how bad this is for your body. Now, just to be fair too, this is a lot of bruising. Usually we don't have that much bruising. So, as far as the science behind this, we have like 24 or more articles from all around the world on all the positive effects of this. And we have our website that you can go to and read all of the articles. But this is not just hearsay. This is evidence-based science showing the efficacy of hypercure and just all of these different things that it does. It doesn't cure baldness though. It does a lot, but not that. So when we think about a patient who presents to you for consultation, and your job is never ever to convince anybody of a treatment. So a patient comes to you with a concern, your job is to diagnose what the problem is, and then to say, these are the treatment options. And treatment options are from do nothing to cut off your legs. So we're probably not going to offer that too much, but we want to have the basic tenets of orthopedics. Number one, that which is crooked, make straight. That which is unstable, make stable. And we want to have joint preservation over joint destruction when possible. So it's not always possible. And not everybody is a candidate for this type of procedure. So that's what we want to talk about is patient selection. So this is critical, like any surgical procedure. So just because they show radiographic displacement doesn't mean that they're necessarily a candidate. We're going to have to grade the severity of it. A lot of times the patient only needs hypercure, but then other times you have to do hypercure plus other procedures. And I can't stress this enough, that we have to look at the entire foot structure and not only at the talus. So, and that's, again, where a lot of people have issues is because they only look at one segment of the foot. Yeah. So, and as Mario said, you know, again, orthotics, unproven to stabilize and realign the talus. This middle picture, I just love it. This is why we showed a lot. This is from the American Journal of Orthopedic Foot and Ankle Surgery. And they said, yeah, this is a good surgery for somebody that has a misaligned talus. This should be the standard of care. And I think that's absolutely absurd. So why, we're going to have arthritis at the talonavicular and calcaneocuboid joint, but they did a great job. I mean, the sinus tarsi is nice and open, but at a big cost. So that's why I say, they kind of missed the target. Instead of doing surgery on the back of the heel and in front of the heel and the midfoot, why can't we just pop this little stent into the sinus tarsi, still have a normal range of motion? We have lots of other options. We can now offer orthotics, and maybe the combination will be great. Or we have to do hallux valgus surgery, heel surgery, whatever. So, okay, patient selection. So we see this is not normal, but how do you know if if hypercure is for this patient or not? Or this one. So, and again, there's this debate about children with this condition with pediatric flat feet, that they outgrow it. And I don't know how many of you actually believe that or not. It's one of the greatest myths on the planet, because there's absolutely not a single case study, not one, that shows this patient, Miguel over here, with his talus displaced like this, and then 5 years later magically it's back to where it's supposed to be. Not one case. But we know that children have fat feet, and that they can have, you can have them walk and that it looks like they have a flat foot, but you have to look at the osseous integrity of the bones. And that's really what we have to look at. So when it comes to foot and ankle examination, and I know all of you are experts on this, but this is just for a simple review, we have to start looking always at the talotarsal joint, and then we kind of go down through the rest of the foot. So whenever a patient comes in with foot and ankle related complaints, that's always where you need to start. The reason why it's so important to start there is because during the gait cycle, the weight of the body is going from the talus onto the foot. And so we want to see the stability or instability there. And then we want to look at the base of the first metatarsal with the first ray, because that's a second really important component, and then the first metatarsal phalangeal joint. So with patients, we want to say, is this a fixed rigid deformity? And if it's fixed, then you can't put in a hypercure. You can't just drill a hole into the talus and put it in and think that you're going to have any kind of results. It's not going to work. So if it's hypermobile, so it's flexible, then they're possibly a candidate. So now we want to look at the first metatarsal to see, is it aligned? Is it moderate or mild hypermobile? Is it excessively hypermobile, or is it in a fix? The reason why that's important is because if we stabilize the hindfoot with hypercure, but we have a hypermobile first ray, that's going to cause a forefoot valgus, and that's going to compromise the results and the long-term success of a sinus tarsi implant. And just like with the range of motion of the first MPJ with hallux limitus, hallux rigidus, if you have limited motion there, you're going to abduct your foot when you're walking as a form of compensation, and that abduction is going to put a lot of strain on the subtalar joint, which can then cause pain from the implant, and then it has to be removed. So identifying these other coexisting pathologies, that's now where we can add a treatment of potentially a orthotic or surgical correction. Because believe me, if we don't have to do surgery, we're all for that. But we don't want to just pretend that a non-surgical treatment is going to fix somebody if they have this condition. Now, to test the talotarsal joint range of motion, we're going to load the fourth and fifth metatarsals just at the neck, and we're going to push a valgus force. And so we're going to be looking at patients later today, so we'll look at this. A lot of times during this part of the presentation, we actually will pick on people from the audience to come up on the stage, take off their socks and shoes and do an examination, but I'm going to spare that from you today. So because nobody had a warning, and I think Mario has some nail polish on or something. So normally somebody should have about 5 degrees. And what's 5 degrees? What's 3 degrees? What's 7 degrees? I have no idea. They're supposed to have some pronation. Okay, but too much of anything is a bad thing. So we can see this is normal. So you can push as hard as you want, and that foot is not going to go anymore. But over here, see, that's like pretty much normal, and then it goes into normal. So you cannot tell me that that's a normal variant. This is bad. This is not good. This is actually a soccer player, football player from Ireland that came to get hypercure. And this is looking at the stability of the first ray. Range of motion. And then you're going to have the patient stand, and then you want to see, can the patient put their foot back into neutral position or not? If they can put their foot into neutral position, then that's a really good sign that they're a candidate for hypercure. If they can't, then that's going to be a challenge. And then we're going to look at the first metatarsal. A lot of times with patients, and again, we're going to see this in a little bit, when they supinate the hind foot, their posterior tibial is pulling up their forefoot, so the first metatarsal is going to be elevated. So we want to make sure that we can push that first metatarsal back down so that they have a normal range of motion there. A lot of times when people have hyperpronation, the peroneus longus loses its strength. And so that's why we get hypermobility of the first metatarsal. And that's why also patients get hallux valgus with this condition. And then the same thing with hallux limitus, hallux rigidus. So once you put the hind foot into neutral position, most patients will actually have increased range of motion in their first MPJ. So we kind of saw this video. But this is somebody that's perfectly a candidate for hypercure. Again, in 10-15 minutes, we can pop that implant in, and their hind foot's now perfectly straight. And it takes the stress off of the rest of the body. This is a foot surgeon from UK who came to me to have the hypercure put in. So again, she doesn't have and that's why I don't really like to call this a flat foot procedure, because not everybody with flat feet has a partially dislocating talus. But you can see, look at the strain on the posterior tib. And again, we wonder, why is it that the posterior tib gets blown out after walking on it for 100 million times? So again, two different, so this is more of a mild deformity, but over here, again, they still have reducibility, but the issue is, look at the first metatarsal, look at the thickness. And one of the reasons why, so what is the tissue over here that's thick? It's the abductor hallucis muscle that's trying to stabilize the first ray. So it's really, really working hard. And I mean, I wish that happened to my biceps, but my biceps aren't so strong like this one. But it can give the appearance of that flat foot. But this is somebody that needs hypercure plus probably a cotton or a plantar flexory metatarsal osteotomy to stabilize the forefoot. If you only put in hypercure, it's probably going to fail. Not a guarantee. But just more. So again, this is the reducibility of the deformity. And this is what we always love, is look at how that foot just flattens out. Look at how the medial column gets so much longer. And that's one of the debates for a lateral column lengthening at Evans procedures. They say that there's a short lateral column, or that the medial column is long. Well, the reason why the medial column is long and the lateral column is short is because of the talus pushing forward, and it's partially dislocating off the calcaneus. And think about the plantar fascia. So, and then we're going to look at the back of the foot, and then you can see calcaneal valgus goes away. So this is why so many people, surgeons, they would go in and perform a medial displacement calcaneal osteotomy, because they said, well, all we're going to do, the calcaneus is in valgus, so let's switch it over. But it's not actually fixing anything. And there's so many publications that show that they try to make it a cosmetic procedure, but MDCO does not stabilize the talus on the calcaneus, not at all. Now, it's important to look at the back of the patient's heel, and not everybody with this condition has a valgus heel. But look at over here at this one. When they go into rectus, the calcaneus goes actually into a varus. So you have to be careful. We never want to have the calcaneus going into a varus. So for a patient like that, we're either going to downsize, or you have to then do a lateral calcaneal osteotomy, which is not too commonly. That's very rare. But of course, we do our gait analysis. And you have to be careful walking behind me, because I might take video of your feet. But so just a warning. But you can just see how this kid, his feet, okay, hyperpronating. But then look at his knee. His knee, like, I don't know if you can see, but it twists. It kind of gives away. So, and then this guy's supposed to go out and run and play and do all this stuff, but he can't. It's not that good. And then later in life, here we are. You know, this guy, he's been wearing his arch supports religiously and spending millions of dollars on them. But just, you know, look at how his hips are going back and forth. He's had back surgery, knee surgery. But, you know, there's his feet. But he's keeping up with his wife pretty good. And then we say later on, you know, why did this happen? Well, this is the tissue reaction. The body's trying to stabilize. And, you know, at this point, this is rigid. This is end stage, and we can't do anything for that patient. So the decision-making process, these, you know, putting in the implant, again, 10-15 minutes, you can't make it last longer. I mean, some people try, but it's very quick. But the decision-making factors are very complex. Now, one thing too that's always mentioned is like equinus, because a lot of people with subtalar joint instability also have an equinus. And you know, there's some people out there that say that anytime you use a sinus tarsi implant, you have to do a gastroc recession or a tendo-Achilles lengthening. But that's not necessarily the case, because once you stabilize the talotarsal joint, then the tendon and the posterior muscles relax because they don't have to stabilize the subtalar joint as much anymore. So usually we see an increased range of motion afterward. But there's other situations that patients have a severe equinus and you have to do a TAL or gastroc recession, but it's just not a given. Now, what do you think about this patient? Because once we've done our examination, we're going to take some x-rays, and you say, okay, well, we have an obliterated sinus tarsi, the navicular has dropped, this is not normal, so are you going to put a hypercure into this patient? Okay, so you don't know. So, okay, that's good. That's good. You don't know yet. So we have to see, is this reducible? Because this x-ray, I don't know, maybe there's a coalition. So we have to rule this out. So we have to make sure that it's a flexible deformity, rule out a coalition. So we should take dynamic x-rays. I'm going to show you what that is. And then we're going to look for everything. So the dynamic x-rays is 2 sets of x-rays, resting stance and neutral stance, for both the AP and lateral. And these are the things that we want to look at. Is the sinus tarsi open or obliterated? We're going to look at the talar declination angle, the simuline, calcaneal inclination angle, navicular position, talar first metatarsal angle, and then to rule out a coalition. Okay. Once you do a couple of these, it's fast. It looks so complicated, but again, I like to make things as simple as possible, but these are the things that are going to run through your head when you look at these x-rays. So let's just go through a couple of these. Sinus tarsi, I mean, that's pretty open. That looks pretty good, so that's normal. Talar declination should be less than 21 degrees. This one's less than 21, take my word for it. The simuline, so this is the anterior edge of the talus and the calcaneus. So this is just kind of an observation. We don't have specific measurements, but the talus should just be slightly ahead of the calcaneus. So this one looks pretty good. Calcaneal inclination is greater than 20, so that's normal. And the navicular should be in the upper half of the cuboid. So if it's below that, then that's bad. That's, again, where you have a fallen arch. Talar first metatarsal is less than 4. So this one, there's no coalition. Okay, so this is a normal patient. It's going to be very rare for you to see a normal patient. So then we're going to compare the normal to abnormal. So let's kind of skip through this one a little bit. But now we see that the talus is more forward than the calcaneus. That's pathologic. Calcaneal inclination angle is normal. So this is not a flat foot, but this is RTTJD. This is like the talotarsal displacement. Navicular is good, but we have an increased talar first metatarsal. And again, I can't rule out a coalition. I don't think that there's one. So let's go now to the 2 sets of x-rays. So if this patient, how are you going to treat and implant this person? What is your options? Arch supports, strengthenings, just do some heel lifts, that's going to fix you. Tibial osteotomy, what are you going to do? I don't know. Send them to your colleague? Send them to somebody else? But then you say, oh, I remember Michael, he said take 2 sets of x-rays. So then we take another set of x-rays. And now our whole world of treatment options has opened up. Now, one thing you're going to have to do is forget about the forefoot, because like I told you, the patient's going to have to really supinate their foot to get the talus realigned on the calcaneus, so we're going to ignore that. So now we take a comparison. Obliterated sinus tarsi, open sinus tarsi. Talar declination angle, very bad. Talar declination, very good. Look at the cyma line. So we wonder, again, medial column was over lengthened and now it's back to normal. Calcaneal inclination angle is improved. That takes a big stress off the gastrocs. Navicular position, look at that, that's pretty big. I mean, that went from negative to positive. And so now we can say, yeah, there's absolutely no coalition. So what treatment do you want to give them? Do you want to go back and cut the calcaneus here? Do you want to do a lateral column lengthening? Do you want to do a cotton or some other procedure there? Or do you want to pop in a little stent into their sinus tarsi to keep it open? Come on, you guys had coffee, it's early. Do you understand me? Right? So does that make sense? Let's try this. Because there's no way in a million years this is going to go away. And every step is destroying their bodies. So now we have a great option for you. So same, but don't get too confident, because this is why we see all of these pathologic findings. The talar declination, calcaneal again is pretty good, navicular drops, talar first metatarsal is pathologic. That's why you can't say this is a normal foot alignment. This is pathologic. This is completely abnormal. But I don't know if this patient can be for hypercure or not yet, because we have to take 2 x-rays. So now you can see this is relaxed and this is neutral. And guess what? Sinus tarsi still obliterated. Talar declination angle still abnormal. Calcaneal, the cyma line still abnormal. Calcaneal inclination normal. Navicular, a little bit better, but not much. So this patient has a coalition. So if it's a calcaneal navicular coalition, then you can resect it and then pop in a hypercure. No problem. But if it's a talocalcaneal coalition, that's a whole different matter. And usually when you have to resect that coalition, it takes the chamber of the sinus tarsi and it creates a flat top on the calcaneus. So you can put hypercure in, but then it's just going to slide right off of the calcaneus. So usually with a calcaneal coalition, you have to do an arthrodesis. You can't use a hypercure, unfortunately. But so again, this one, now we can see a difference. We see reopening of the sinus tarsi. We see improvement of talar declination. The cyma line is so much better. Calcaneal inclination, again, no change really. The navicular is lifted up, so instantly that takes the strain off the posterior tibial tendon. What else? So this one, yeah, we can use hypercure. Again, just another, this is an adult. So we see all the bad things that we talked about already. But anytime you see this dorsal spurring, you have to automatically think there's a coalition. So this patient has a calcaneal navicular coalition. So you have to go in and you can cut that out. But again, you have to be very careful not to remove all of the surface up there. Just take off a little bit. And then you should be okay. So you see the difference. So this one, this is more obvious that there's a coalition back here. So don't think that you can just jam hypercure in, it won't fix anything. So usually telonavicular coalitions 3 to 5 years old, calcaneal navicular 8 to 12, and telocalcaneal is 12 to 16. So we've had a couple of cases where surgeon put in hypercure in a 10-year-old, and then they came back 4 or 5 years later and they said, I'm having issues. And they took x-ray and they said, oh, you have a coalition. And then the surgeon thought, well, did hypercure cause the coalition? Well, no, it would have happened regardless. And that doesn't mean that you have to wait until somebody's 16 years old to rule out a talocalcaneal coalition to use it. You just have to be aware that once in a while that can happen. Now, I love this x-ray because the patient went to the surgeon for hallucizologous surgery and came in like 2 years after the initial surgery with the same exact pain in the big toe joint. And the patient went to somebody else. And so he noticed that the patient had a misaligned hindfoot. And look at the difference between the screws before and after. And we can see open sinus tarsi, the tiller declination angle has improved. And again, you have to just think about when this patient's walking and the talus is jamming forward, what that does to the first metatarsal bone. So you can see this is why the medial column gets longer than the lateral column. It's because of the talus pushing forward. And the funny thing too, or not funny thing, is that the surgeon did perform a medial displacement calcaneal osteotomy. So the patient had the original surgery and then had the screws removed from the MDCO, and then end up with the same complaint that they started off with. Not a happy patient. And probably all this patient needed was to have a hypercure put in, and that would have taken away the pain. Okay, so let's go to the top view, and there's some things that we want to see. So normally the bisection of the talus should be within the first metatarsal bone. And anytime it's medial to that, that's where we have a transverse plane deformity. And we don't measure the talo first metatarsal angle because so many times patients have a deviated first metatarsal bone. So the second metatarsal bone is really the axis of the forefoot. So this should be less than 16 degrees. Of course, we're going to look at navicular coverage, simul line here, and then also look at the metatarsal length. That's really important. I had another patient contact me. His first metatarsal is really long, and so after he had hypercure put in, now he's walking overly supinated because they should have shortened his first metatarsal bone. So it should be shorter. We look at the intermetatarsal angle, and then you also have to make sure that there's no metaductus. So see how this is a big IM angle here. So if you did the talar first metatarsal, it would be normal. But this patient has a transverse plane deformity. That's absolutely abnormal. And usually with this transverse plane deformity, if you see this on x-ray, ask your patient, how are your knees? Especially like an older patient, and they're always going to say, oh, my knees, they're sore, because they're getting that twisting, or their hips are pulling in. And that's the same thing with people with IT band, iliotibial band issues, because it's trying to strengthen the pelvis because of the whole hyperpronating foot. So there's all these different things to see. That's why foot surgery is so much fun. It's not boring. So many things you have to look at. So this is a comparison between neutral stance and relaxed stance. There's going to be a quiz on this later on before you leave. So. But so look at the fibular sesamoid after this procedure. You know, it's still not perfect, but then once we realign the hindfoot, it's absolutely centered over that. And I didn't take these x-rays. This is not biased. This is not me like making sure that this is perfect. So this patient has a metaductus, so you have to be careful. And if you put hypercure in, you can make this even worse. So you have to identify this and either perform other osteotomies here, or you just don't have as much correction of the hindfoot. You kind of compromise it. Now, when you get fancy, this is where you do the weight-bearing fluoroscopy. And this is really important because it helps to show you if the patient has a flexible joint, and it also helps the patient to understand what's going on with their foot so that they can make an informed decision as to what treatment is the best for them. And this is what I would do in my clinic, especially when they would come in with arch supports from other doctors, and they would say, please don't make me buy another pair of these. And I say, no problem, but let's have you stand on this thing that you spent so much money on and see if it's helping you, and you can just see how the talus is not having any effect whatsoever. So that's why orthotics, I mean, again, they're good for some things, but not when it comes to the talus. So then I've tried to create this because, you know, with hypercure, the maximum correction is 37 degrees, and this is from published data. So if somebody has a deformity greater than 40, chances are we can't bring it back to normal. And that doesn't necessarily mean that they're not a candidate, but you just have to lower your expectations that we're not going to make them absolutely perfect, because some correction is better than no correction. So it's like that a patient with diabetes, you know, like take some insulin or take something once in a while, that's better than nothing. And then sagittal plane 2, this is an important picture. Maximum correction in the sagittal plane is 19 degrees. So if their talus is perfectly up and down vertical, then you can't assume that we're going to make it absolutely perfect, but we're going to make it better without having to do an arthrodesis procedure. So that's where we say we have like a grade 1, grade 2, grade 3. And just so you remember, we have these in Spanish so that you can go through and make all of your marks to think, is this patient a candidate or not for this procedure. And as Mario had on the bottom of his slide, that hypercuredoctors.com, we have so many webinars, so many articles. There's like a whole, this is that secret knowledge base that's out. It's not, we don't want it to be secret, but it's there. Okay, any questions? No? You got it? Okay. And it'll be good when we look at the patients today too. The clinical thing is very helpful. So then what I want to do is, we have what I say is an ideal patient, and this is their measurements, less than ideal, and a high risk for failure. And because sometimes you'll have a patient that maybe they need to have a triple arthrodesis or a much more radical procedure, and you say, well, let's give this a try. If it doesn't work, we can always remove it, and then we have other options. But there's a good chance that it could help you. So when it comes to presenting this to patients, we do not say that it's 100% successful, because like I said, nothing is 100%. So when somebody is an ideal candidate, I mean, our published reports have about a 94 to 96% success rate. But I want to be more pessimistic for patients and say that it's a 90%. I'd rather be, it's the old saying, you want to under-promise and over-deliver. So I don't want to set up their expectations too high. Less than ideal, again, this is not evidence-based, but this is just, you know, being careful, being a good doctor. 75%, high risks, 50-50, and then you have a not a candidate. But, and again, this is just kind of going over some of the before and afters, showing the transverse plane correction. So, and like this patient here, this is a negative calcaneal inclination. You can't just put a hypercure in and think that you're going to fix this patient. This patient definitely will need a TAL, because to try to get the calcaneal inclination angle up, and then hypercure, and probably even a first-rate procedure too. And then even this is kind of risky, but people always say, you know, if you're running or playing, jumping, are you going to have a calcaneal fracture? And this patient had a cyst, and the surgeon still put hypercure in, and it's no problem. So, because again, the weight of the body goes posteriorly and anteriorly. There's very little force acting on the implant itself. So, this is the other thing too is, you know, yeah, we fixed the hind foot, but we still have a problem over here. So you can't just put hypercure in and not address this. This is going to compromise the results. Or if you have a coalition, you can't just jam it in thinking that you help the person. And yeah, that's a problem. And this is another situation where this patient was not really a great candidate, but the surgeon still put it in, and it took off enough stress that it decreased their symptoms. So you might not want to show this picture to your friends or colleagues, but the patient's happy. So ultimately, we want a happy patient. As far as like the ages to use the implant, 3 years old is the youngest. Now, I'm not saying that every 3-year-old patient with flat feet, you have to put this into them. But 3 years of age, the reason why that's the youngest you can do is because that's the point when the sinus tarsi becomes ossified. Now, everybody's kind of different as far as when do they start actually performing this procedure. Some surgeons say, I don't care, I'm going to wait until my patient's 16 years old, and beyond, until they're 16, forget it. And so they put it in 16 years old, they had great results. But then they have a patient who's 14 years old that comes in and you're like, man, this guy, he's going to be a good candidate for this procedure. So do I need to make this patient walk on these bad feet for 2 years and then come in and get the procedure? So they say, well, you know, Bram said we could do it in 3, so maybe 14's okay. So they put it in the 14-year-old. And the 14-year-old running, playing, great result. And then they have the 12-year-old come in, you know, so it kind of like slides like that until then, you know, you kind of do it younger and younger. As far as the oldest patient is 94, 94. So just as long as you're flexible, it doesn't matter. Now, I know one of you wants to ask the question, but you're too scared to ask it. What happens when you put hypercure into, say, an 8-year-old, and now they're 21, their bones are grown? Are you going to have to switch out and put a different implant in? So what do you think? How many of you think you're going to have to switch it out? Nope. So it stays. Okay, good. That's really good. I'm impressed. Yeah. So as the, you know, like, so the owner of the company that makes the implants, so the most common adult sizes are 6 and 7. Okay, the most common adult sizes are 6 and 7. So if you put in a 6 and 7 into your child, they already have the most common adult size. So it's unlikely, but there's no guarantees in surgery. So we tell the parent, it's unlikely that we're going to ever have to change this out once they become older.
Why the poor bone quality?
You know, that's the lawyers. That's the lawyers. So there's no number on that. And like I said, I had that showed that one with the cyst. You know, it's not a problem. So, but the lawyers say, well, you should put that just in case. You never know. So, yeah. Okay, Mario, what should we do? Just go surgery? Are there any surgeons here? You guys want to see some surgery, right?
No. Lo que acabo de contar Mike recién era lo que preguntabas vos, Juan Carlos, con respecto a las indicaciones. Es obvio que las indicaciones, las contraindicaciones son absolutas. ¿Sí? Paciente con varo, paciente con metatarso varo, son absolutas. Un paciente que tenga un pie que no sea flexible no se opera. Salvo que tenga una coalición tarsal, la rompamos y lo coloquemos. El punto de la edad, es en lo que yo difiero a veces con Mike. My idea is to operate on from 7 or 8 years old, because the stability of the patient. Pero yo no digo que no haya que operarlo antes. Estoy diciendo que mi experiencia, my experience begins from 8 years old until 99. Yes? Siempre y cuando sea un pie flexible. Todas esas mediciones de ángulos están todas en la literatura, están todas en lo que dijo el doctor Graham. Y bueno, vamos a hablar de la técnica quirúrgica. You are going to speak about the surgical technique?
Yeah.
Mario,
Dime.
agregar algo ahí respecto a la edad de inicio. También, pues,
Si tú tienes un pie que va a ser rígido, generalmente va a ser alrededor de los 12 años. Entonces, operar a un paciente antes de esa edad es complicado. O habría que a lo mejor estudiarlo un poco más. Ahora, lo otro, yo personalmente he usado artrosis, calcáneo stop, en pacientes con barra sin resección de la barra. Y corrige, y hasta el momento los resultados también han dado bien.
I try to translate it.
Okay.
He's talking about the age.
Yeah.
He told us about if you have a children 3 years old, 7 years old, and you think that at 12, 15, he's going to have a tarsal collision, you need to study so much this patient. ¿Está bien? Okay, y lo otro, he says that he put into the feet of a patient with a tarsal collision, calcaneal stop, and he worked it. You're lucky.
Yeah. Sure.
Oh, it's
Sure.
not-
Makes sense.
Only in the surgery we move. break the.
Yeah.
Sí, sí, lo que dice aquí,
Without remotion of the collision.
Mhm.
no,
Yeah.
no moverla, no,
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 but-
no hacer recepción.
Without
Sure.
restriction.
It makes sense. Yeah, I mean, it stabilized the whole foot.
Yeah.
No problem.
Okay.
Yeah. Perfect. Okay. So, when we talk about surgery, and however old the patient is, we prefer to do 1 foot at a time. And it seems like it would be so much easier for the parents, for you, for the surgery, for the patient, everybody, to do both feet at the same time. But this really should be avoided. It's not a contraindication. But the reason why is because when you do both feet at the same time, the patient is going to over-supinate when they're trying to walk. And that over-supination can partially displace one of the implants. In my experience, and other surgeons' experience, when you do both feet, it's a much longer recovery. So usually you like to do 1 foot, and about 4 to 6 weeks later, you do the other foot. Now the soonest I've done the other foot is 6 days. But that's usually when patients were coming internationally. But really the general rule is as soon as they can put full weight on the foot with hypercure, then you can do the other foot. So, yep. Something else, when you do 1 foot at a time, that foot with hypercure will be painful, will be sore until the other foot has hypercure. And so you have to warn patients about that. It's like putting brand new tires on one side of the car and you have flat tires on the other side. The new tires are going to get worn out. Say, what's wrong? These tires are bad. Well, it's because, again, the biomechanics aren't completely settled yet. But again, it's preferable to do both feet. A lot of surgeons do both at the same time, and it is what it is. But anyway, so usually like 4 to 6 weeks later, you do the other one. Now, yeah, and so that's the compensated gait. Now, one of the big things that's super important is looking at the shoes of the patient, because usually we wear out the posterolateral aspect of the shoe, and that's going to over-supinate it. So this can cause the implant initially to displace. Now, usually, let's say you put this into a patient, they had a great recovery, they come in a year later or 2 years later and say, man, I don't understand. All of a sudden out of nowhere, it's so sore around my ankle. And you say, okay, let me look at your shoes. And usually you see the shoes and it looks like somebody took a saw and cut the back part, so it's over-supinating it. So first, most surgeons, they say, oh, it's this implant, we have to take the implant out, you have a problem, complications. I mean, you still take x-rays to make sure, but usually you say, no, I don't understand, the implant's right where it's supposed to be. And again, you look at the shoes, you say, throw away the shoes, buy new ones, and that's good. For the adult, like especially women, they're very happy afterward with the surgery because they get to go out and buy all new shoes. So the husbands, they're not so happy. So you have to be careful. Be careful. The landmarks. So like any surgical procedure, landmarks are important. We don't want to struggle. This should be very simple surgery. So we have the lateral malleolus. This is the anterior calcaneal prominence. And so this is the anterior posterior border of the sinus tarsi. Intermediate dorsal cutaneous nerve, sural nerve, and there's a communicating branch. So the area, the soft spot over just below the fibular malleolus, the lateral malleolus, that's the sinus tarsi. No nerves, don't have to worry about cutting anything, but in our incision, we only want it to be about 2 centimeters. Don't make a big incision and then cut the intermediate dorsal cutaneous and the sural nerve, unless you like doing nerve surgery and you can repair those. But try not to do that. Now, this is something else. Usually, like patients will have, like, I don't know. So, like in the States, they just do like a twilight sedation, right? So, not easy sedation, especially for the adults. Children, maybe you need to do a general. Now, so like I was just in India and we did the surgery there, and so they did a spinal for the patients, and I said, okay, well we have to do an injection in the sinus tarsi, and the anesthesiologist, he's looking at me, he says, no, they have a spinal. But I said, listen, when this patient wakes up, we want this area numb. So we don't want them to wake up and they have all this pain in that area. So before you make an incision, please put in like a long-lasting anesthetic in there. And I highly recommend using a short-acting steroid at the same time. Now, usually we don't combine local anesthetic with steroid in surgery, but this is the exception to the rule, because the reason for post-op pain is from the inflammatory reaction. So if we can decrease the inflammatory reactions, patients have less pain and they have a faster recovery. And especially the soft tissues within the sinus tarsi are not very vascular. So when they take medicines to try to decrease the inflammation, it doesn't really reach down there. So if you can put the medicine, the steroid, right in the sinus tarsi, it speeds up the recovery big time. So very important. Otherwise too, like some surgeons, they do an ankle block. You don't need to do an ankle block and cause all of this pain around their foot. Just a sinus tarsi injection. That's it. Very simple. And then we're going to use a number 15 blade. Don't use like one of those big machetes. Like some surgeon, I'm like, this is like minimal invasive surgery, so just a little 15 blade. Now, this is our best friend. This is called the Stevens tenotomy scissors, because we have to go in and decompress the ligaments within the sinus tarsi so we can do the rest of the procedure. So these are curved and they should be sharp. So we stick it into the incision and open it up, and that's the superficial dissection. And then after that, we're going to go in and cut the interosseous ligament. Now, for some surgeons, they go crazy when I talk about cutting this. They say, oh my God, if you cut the ligament, the foot's going to fall on the floor. No, we're replacing the function of this ligament. It's not working. And so what keeps hypercure in place, and this has always been the problem with the other extra-osseous implants, is that they pop out. So we cut the ligament, and then when you push hypercure in, the ligament grows around the threads, and then it prevents it from backing out. So very important. Okay, so we push it in, and then the ligaments are going to attach around there to prevent it from backing out. Now in older patients, it's worrisome because when you cut the interosseous, there's nothing there because the talus has been grinding on it for such a long time. That could be an issue. That could lead to problem because we don't have the anchoring. So it's important to remember the sinus tarsi goes posterior. So the curve of the scissor has to go posterior. This is the first mistake that surgeons make, is that they have the scissors going the wrong way. They go in and cut, and they don't cut into the canalis portion. And then when they do trial sizing and put the implant, it's going to pop out later. Not that hard, very simple to remember. Just aim to the posterior aspect of the medial malleolus, and you just got to cut. You're not going to hurt anything. You're not going to cause avascular necrosis of the talus. No problem. You just put the scissors in and you just cut. You do it blindly, no problem. Take them out, put them back in. You go this way, that way. You can't overcut, but you can undercut. And it feels like you're cutting rubber bands, celery, and different things. So super important. And you don't have to go all the way through medially, and you don't have to look at it under imaging. But that's what it looks like. You're just snipping away so that we can create the entry point. Now, Mario, he doesn't use this one. This is the second generation implant that we don't have regulatory approval in Argentina yet. But this is the one that we're now bringing. This is the one we want to use here and everywhere else. There's nothing wrong with the number 1 version of Hypercure. We're still using it, very successful. It'll never be taken off the market, but this is just the second generation. So this is the driver, and then these are the trial sizers, because we have to determine which size implant, the stent, is going to go in the foot, and then everything is cannulated.
May I?
Yes, please.
Put the instrumental box. La versión 1, el tipo 1, tiene 6 trials, 6 probadores distintos, del 5 al 10. Y en este caso los probadores son como si fueran los implantes que se colocan en el atornillador y los vamos probando.
en este caso. Esa es la diferencia y hay alguna otra en cuanto a la forma del implante. El problema es que en Argentina estamos para atrás, entonces de casualidad, we are broken in Argentina, so we can put tape 1 only.
It still works.
Y funciona.
There's nothing wrong with it.
Perdón por la interrupción, pero la...
There were surgeons, when I came out with this next generation, they said, please don't take Hypercure 1 off the market. We love it. We love it. I mean, the main reason I came up with this one is because the Chinese were copying my other one, so I had to make another one. There's like, I don't know, so many companies, whatever. So this is the sizer. It's smooth because we don't want to have, we want to have an atraumatic technique when we're putting it in. So we have a guide wire that we're going to place into the sinus tarsi, and this should be the first test if you cut the ligament or not, because it should just be very smoothly entered into there. If you have any resistance, get the scissors and recut. No problem. No extra charge. And then this is just going to be threaded, I know it's a small picture here, but it's going to be threaded onto the end of the driver. I'm giving an explanation. And I'm doing this upside down for the demonstration. But you see, we just push it along the natural orientation of the sinus tarsi, and you can't over-insert it. That's what's so great about this procedure. With the other implants, you can literally push it to the other side of the foot. With this one, it's self-seating. It just pushes, and then we're going to push onto the, check the range of motion. Here we go. So again, usually we're at the bottom of the bed. We're going to push as hard as we can on the lateral column, and we just want to see a very little bit amount of pronation. So we're looking at the lower leg to the forefoot. And we just want to have a few degrees. So the whole goal here is some pronation. Again, 5 degrees, 6 degrees, 7 degrees, 3 degrees, just a little bit of pronation. Now, we should check, especially early on, because you want to make sure that the sizer is deep into the sinus tarsi, if it's not sitting too superficially. If it's sitting like this one, that means we didn't cut all of the ligament. And this is acting more like an arthroeresis and potentially going to have a higher failure rate. So we want to lower that removal rate as much as we can. So you can see, push it in as deep as I can go, and I can't make it go in any deeper. And then we're going to get just a few degrees of pronation. So you go through the different sizes and until you have like no pronation, and that means you've gone too far. And when you're checking them, if you have two sizes, size 7, size 8, that they look like the same amount of correction, always undersize. Because initially surgeons always go too big. They say, well, when the patient's walking, they have more weight, so let's try size 8. And then the patient comes over supinated. So whatever you see on the table, that's what you put in. Okay. Now, one thing that I spend a lot of money on is making sure about the sterility of these implants. It's so many validation tests every year, every couple of months we go through that. So each one of these is individually sterilized. Again, these are made out of titanium. You can go through, I carry 2 with me everywhere I go, walk through all the metal detectors, no problem. So, one on my right foot, one on my left foot. So with this one, this is a slightly different sizing from Hypercure 1. So the 7 and 8 are the most common sizes of this one. And one of the issues that, not that big of an issue, but something that some surgeons told me is they felt when they disengaged the driver from the implant, from the other version, that it could potentially like move out the implant a little bit. So I created this positioning sleeve that fits on here so that this keeps the implant 100% in place. And so the implant is screwed onto this, and then there's little notches on the back that attach to this, and then it comes off. And why I have pictures is because it's easier to see the pictures than hearing me trying to explain it. So I'm going to show this. So we're going to push it in, and you want to make sure that it's beyond the lateral neck of the talus. Okay, just anywhere deeper than that, we're going to be happy. If it's too superficial, we're not happy. So it goes on the guide wire. We're going to push it in as deep as it'll go. And you take out the guide wire before you're fully seated, because sometimes I can put a little bit of a bend on the wire. So when you move the wire, it can displace it. So we could have done at least 3 or 4 surgeries with me just talking about it right here. So it's much easier. So this is just everything coming off. So you hold the positioning sleeve, you reverse this, and then everything just kind of pops off. So there's zero motion of the implant. And it's perfectly in place. And then you recheck the range of motion. This is deep. Usually it's not going to be as deep as this, but you want it somewhere. And every single foot is different. This is not like performing usual ORIF where the screws are 100% exactly the same every single time. Every one of these are going to be more deep, a little more superficial. It's a wide variety. Usually it's just a couple of stitches in the skin, bandages. Patients are pretty much ambulatory. You want to have minimal walking, but they can walk on their foot pretty much the same day. But that doesn't mean to go, running and walking to school or anything like that. After a couple of days, 3 days usually, and everybody has different protocols, but after usually 3 days, you cut the dressing off. You can put a Band-Aid on the incision, take a shower, take the Band-Aid off, put a new one on after the shower, and back into shoes. Again, some people have very little pain, other people have a lot of pain, and it varies from foot to foot, even though it's the same technique. What else? And then usually, people get like good day, bad days because they're feeling better, they have less pain, so they go out and they do a lot more walking, and the next morning they have a little more pain because they overdid it. So I always say, listen to your feet. If your feet are hurting, that means you did too much. So take it easy, or if they don't hurt so much, then you can be a little more active. But then as soon as they start hurting, okay, you need to take it easy. We say no running or jogging for about 6 to 8 weeks, around that point, because displacement after 4 to 6 weeks is less than 1%. So if it's going to move, it's going to happen pretty early on. Now, if at 8 months, they're saying, I have so much pain, I can't walk, I can't put pressure on my foot, then you need to start thinking about giving them some injections, like a steroid injection. You want to take an x-ray and just to make sure that there's no issues with the implant. And that, of course, that you've done the other foot. You have to put hypercurrent to the contralateral limb. But we always say full recovery can take a year. Even though it's a 10-15 minute surgery, somebody's been walking one way their whole life, and now they're walking differently, so their body's going to have to adjust to it. So, okay, Mario, do you want to say anything? And then I want to go complications.
Yes. I want to tell them my experience, some tips. Chicos, cuando yo tengo duda, cuando tenemos duda de dónde estamos, porque la orientación de la endortesis, la orientación primero del clavo de Kirchner es fundamental, porque ahí vamos a colocar el espaciador y después vamos a colocar el stent. El primer tip que yo hice cuando puse el primero, porque uno no tiene tridimensionalmente donde está parado cuando va a entrar con el alambre. Entonces, la mano contralateral, ¿sí?, el índice o el medio, toca el maleolo interno, ¿sí?, y antes de cortar el ligamento, first of cutting the ligament, yo pongo el alambre. Como no tiene punta, tiene que ser un alambre romo para no atravesar la piel del otro lado, porque puede suceder, lo empujamos y tocamos el alambre que sale debajo y detrás del maleolo, ¿sí? Entonces ahí estamos seguros de que estamos con la dirección correcta. Luego usamos la tijera de Stevens, como decía muy bien Mike, cortamos. Si se sobrecorta no pasa nada, no hay nada que rompamos. El problema es si cortamos de menos. Ahí está
la cuestión. Y después vamos colocando los sizers. A medida que vamos colocando los sizers, desde el 5 hasta el 10, vamos midiendo, como muy bien indicó el doctor Graham, la pronación del antepié. ¿Por qué no buscamos la pronación del retropié? Porque no medimos nada allí. El pie se prona debajo del astrágalo. Acuérdense que el concepto es que el astrágalo es un hueso que no forma parte del pie desde el punto de vista funcional. Todo el problema del pie es subastragalino, porque se evierte. En cambio, en el pivot se invierte. Y el pie del pivot, eso no es un problema subastragalino. Sí lo es. Entonces, ¿cuál es la idea? Probamos. Cuando tenemos duda, como lo dijo hoy el doctor, si va un 7 o un 8, pongamos el 7, porque es mucho mejor. Respecto a la deambulación, como bien decía él, lo dejamos una semana, solo una semana. Y lo que nosotros le agregamos desde el punto de vista del postoperatorio, de la kinesiología, de la fisioterapia, es, a ver, convengamos que si yo camino así, voy a tener un sobreestiramiento de lo medial y una contracción de lo lateral. Estoy con un desbalance músculo-ligamentoso. ¿Sí? Por eso se corta el Aquiles, por eso se cortan algunos músculos y se alargan otros. ¿Cómo hago yo para rebalancear? Hay una técnica kinésica que se llama RPG, Reeducación Postural Global. Postural Reeducation, no me acuerdo más. Pero es una técnica que creó un francés que se llama Philippe Souchard, y que no solamente sirve para el preoperatorio y del pie, sino que sirve para todo el organismo, y que se basa en reacomodar, rebalancear. Era ese el otro tip que yo les quería dar, además de lo que bien nos contó con su claro inglés el Mike, el doctor Graham. Y bueno, nada, después de esto, si tienen preguntas, si quieren hacer alguna aclaración. Doctora, ¿dónde está la doctora Ana María? Póngamela.
Voy.
Ok, ahí le llevamos el micrófono.
El doctor mencionó que la indicación va desde los 3 años.
You told them that your indications are from 3 years.
Yeah.
Why?
Scientifically speaking, 3 years old is the youngest, but we don't, like Mario said, usually 6, 7, 8, it's older. It's not commonly performed in children 3 years old. I had a patient though, this guy, you know like the football in America, the Super Bowl. This guy is the producer of the halftime show of the Super Bowl. Big, very powerful guy. He brings me his son, 3 years old, and he says, I see these implants, this hypercurist, you put it in my son. I said, but he's 3 years old. Wait till he's older. And he says, but look at his feet. His feet were so bad. And they made braces for his feet, and he's trying to walk with these braces, and it's horrible. And he says, what's the youngest you can do? 3 years old. I said, my son's 3 years old. He's 3.5. He's older. Why can't you do it? And I said, please, wait a couple of years. He's like, it's not going to get any better. And so I was trying to convince him, and so it was the other way around. The night before surgery, I was so scared. I'm like, oh my God, this is going to be so bad. I don't know what's going to happen. And I did both at the same time, just because of the, and when I made the incision, I put the implant in, and it restored everything. It was amazing. And afterward, this child, I mean, his was perfectly straight. It was so amazing. So why wait 5 years? Again, but usually it's not so dramatic. That's why, and that's why we don't want to, we're not saying this is just a cosmetic issue, you have to wait for pain. I'm not even going to go there, but this was bad. So a year later, after I put these in, the mom brought the boy back. And I said, how's everything going? She said, it's horrible. You have to remove the implants. I said, why? What's the matter? She said, before I put him down and he would stay right there playing with his toys. Now he's running everywhere and I can't keep up with him. So she was so happy. She's like, you've changed his life with this little procedure. But again, but everybody, it's a philosophical thing as far as the age. Like I said, some people, they say no, 10, 12, 14.
Bueno, doctora, vos iniciaste la pregunta con eso, pero tenías una pregunta.
Sí.
Ahí va.
Mira, puede ser porque no entendí o en algún momento me desconecté. Pero la indicación se basa en la imagen radiográfica, de medidas radiográficas. ¿Qué pasa con la sintomatología de los pacientes?
Ahí vamos. A eso iba. Y estaba esperando esa pregunta, viniendo de gente con criterio e inteligente desde la ortopedia infantil. No es como decimos en Argentina, pasar la vaselina, es la verdad. She's talking about symptoms. Nosotros decimos esto. Todo acto médico comienza con la consulta médica, ¿sí? La consulta médica empieza en el tete-a-tete, cuando uno habla, escucha, en este caso a los padres, que el chico tiene un problema. ¿Qué problema tiene el chico? Viene, doctora o doctor, mi hijo camina así, gasta los zapatos adentro, tiene esta dificultad. Ok, lo revisamos, probamos la pronación tal como lo describió Mike, sacamos radiografías, 2 pares de radiografías, en stance, es decir, en relajado y corregido, y vemos la diferencia entre una y otra. A partir de allí, hacemos o no hacemos la indicación. Cuando decimos dolor sí, dolor no, estamos en binarios. Estamos pensando blanco, negro, Colo-Colo y el otro equipo, ¿cómo se llama?
No, existe la Chile.
¿Cuál es? Sí. Bueno, estamos pensando en binario. ¿Por qué? Yo le pregunto a usted, doctora. Usted hace ortopedia infantil algunos años. Hace ya, ¿qué está haciendo?
Pícaros años. Sí.
Pícaros años. Cuando tú tienes un genuvalgo que llega con una deformidad a los 10, 12 años, no hablemos de la corrección esa nueva que hay que empieza más temprano. Cuando tenés un genuvalgo que está por fuera de lo normal, ¿lo operás o lo dejás seguir?
Es que, por eso le pregunto, porque eso ya está definido. Hay una curva de corrección y si pasa esa curva, o sea, si no corrigió, tiene indicación quirúrgica.
Perfecto.
Pero
¿Con
en
dolor
este caso,
o sin dolor?
es que los genuvalgos no tienen dolor, pues si tiene dolor es otra cosa.
Y el
Pero en este caso, en el caso de los pies, tal vez estoy pensando en el concepto antiguo que decías tú, de pie plano, valgo fisiológico del niño asintomático, que en algunos casos corrige y en otros no durante el crecimiento hasta los 6 años, 5 o 6 años. De ahí para adelante uno ve pies
Estamos de
planos o
acuerdo.
no.
Sí, sí.
Pero hay pies planos que no son sintomáticos, que son cosméticos, que están en el medio, que están ahí, porque claramente un pie que no duele, pero al hacer el stand o en deporte es un pie ineficiente.
Perfecto.
Entonces,
¿Ya?
So this is the debate about waiting for symptoms and no
Yes.
symptoms.
Yes.
Okay. Go ahead. You say yours, but then
I
you begin and then.
Yes. He defends me. He defends me.
No.
The idea is this one. Yo vengo de la ortopedia infantil. Yo opero genuvalgo de la misma manera y con la misma indicación que tú. ¿Por qué lo opero? Porque yo sé, como todo ortopedista, que hay que fijar para que no se tuerza. O que lo que está torcido lo quiero enderezar. Genuvalgo se corrige así. Con el remanente de crecimiento que tengo, con una hemi epifisial de sí lo corrijo, ¿sí o no? Perfecto. ¿A ese chico le duele? No le duele. El dolor es un síntoma. En semiología tenemos síntomas y tenemos signos. El signo de que camine con un pie hiperpronado, sabemos que le va a causar un problema, como también sabemos que una rodilla valga le va a generar problemas cuando sea un adulto. Ese es el concepto, y es el debate, ¿eh? Ojo que no estoy diciendo que lo que vos digas está fuera de lugar, todo lo contrario. Nosotros estamos convencidos de que el síntoma dolor queda fuera de combate. ¿Qué pasa si tiene un chico con un pie con dolor, un chico? ¿En qué pensamos primero? ¿En que tiene una barra?
Un pie plano doloroso.
¿Pero por qué
claro.
va a doler un pie
Pero la
plano?
pregunta va a niños con pie plano, radiográficos, clínicos, sin dolor.
Los operamos.
Sin dolor,
Los operamos.
independiente de la edad.
Independiente del dolor. ¿Eres?
So this question always comes up, and I don't. Again, my Spanish is not so good, so please forgive me. Hopefully, I'm not repeating, but this always comes up. It's come on. There's no symptoms, and he's running, playing, and we're not dealing with a life and death situation. We don't have to rush the patient off to have a surgery, okay? But again, but it's a little bit of a philosophical thing, and again, we love to say when you have pain, then we'll perform this procedure, and that's fine, and that's where we have common ground. No problem there. That's no debate. But then the other question that comes into play is, and this is what happens. Life happens because you have a child who's who eventually is going to become symptomatic, like we're talking about, all the heel pain, all these other things. But like I said, life happens. So now you're in college, you get married, you have children, and you don't have time to do it. And now maybe it's too late. And so now you get into this thing, and you're like, man, I wish I would have had this done. And now I'm overweight, and I have all these issues. And then you finally say, okay, now I want to have the surgery, but now it's not an option anymore. But again, that's a whole other topic, and it's like a religion. We were talking about it earlier, that we're not here to convince anybody of anything, just like we never want you to convince a patient to have surgery. So.
Y agrego algo más, Ana María. Cuando viene un paciente al consultorio, lo primero que uno hace, ¿qué es? Escuchar por qué viene. Y si yo escucho que para ese chico, o ese adulto, si viene un adulto, es un problema, le pregunto, ¿tiene dolor? No tiene dolor. Pero yo veo que hiperprona el pie, yo veo que gasta mal el zapato, yo veo que tiene una marcha que no es normal. Es mi obligación decirle, bueno, mire señora, este nene tiene esto. Tengo ahí por ahí un modesto librito que escribí para que lo entiendan los papás, porque en media hora de consulta a veces no sirve, pero lo escribí a propósito. Lo escribí y lo hice leer por 100 no médicos para ver si se entendía. Y la idea es solucionarle el problema. No porque venga, vas a andar por la calle y ves un chico con pie plano y le preguntas, ¿tenés dolor? No, te opero lo mismo. No. Perdón por la exageración, Ana María. A lo que yo voy es a que si yo veo algo que está mal y que sé que va a generar un problema, y lo comparo, con perdón de los presentes, con el genuvalgo. Si yo dejo pasar un genuvalgo y cuando tiene 40 años tiene una artrosis del compartimento lateral externo de la rodilla, y estoy haciendo mala praxis, o por lo menos no me estoy haciendo el boludo, como dicen en Argentina, ¿no? Insisto, como dijo May, no queremos convencer a nadie, y mucho menos a gente razonable e inteligente y con criterio. Cada uno debe usar su criterio. Está muy bueno lo que vos preguntás. Está muy bueno y además tiene respuesta. ¿Alguien más?
Bueno, si me
Pero sí,
dejas agregar,
vale.
yo creo que hay casos y casos. O sea, todo tiene una indicación y una contraindicación, y hay un espacio en que uno tiene dudas razonables.
¿Sí?
En esas dudas razonables yo creo, bueno, aquí hay muchos doctores que están en formación, yo creo que en ese espacio de dudas razonables sí hay que hacer seguimientos, hay que buscar más evidencia, hay que dar un tiempo de evaluación y ver.
Absolutamente
Y
de
ver.
acuerdo.
Absolutamente.
Entonces, un poco para allá iba la pregunta.
Bien,
Porque
perfecto.
sí, si hay niños que a los 3, 4 años necesitan y a veces uno con susto hace cosas un poco salidas de la norma de la evidencia, pero claro, si hay duda, hay que esperar, hay que ver qué hace y conversar con los padres. Los padres son los mejores observadores, los mejores termómetros de las cosas.
Absolutamente, absolutamente. Ahí, hablando de dudas razonables, voy a hacer un chiste. Teníamos un profesor de filosofía, yo empecé en la carrera de Derecho a la vez que Medicina, y no la terminé porque no me gustó. Y el tipo era profesor de filosofía, entonces se paraba delante tuyo y te explicaba sobre el método, qué sé yo. Y después preguntaba, ¿dudas razonables? Y nadie respondía. Pero yendo a esto, hay una franja de sombra. ¿Estamos de acuerdo? Hay una franja de sombra. Y todo lo que uno hace con los papers, publicando cosas, digamos, para afirmar lo que uno está diciendo, es para poder llegar a cumplir lo que uno juró cuando se recibió de médico, que es, dicho en latín, primum non nocere, ¿no? Que es primero el no dañar, porque nuestra idea es ayudar. Y bueno, esa es nuestra idea. ¿Vamos a ver pacientes?
Sí.
Gracias por el debate, porque si no se es aburrido.
Una consulta,
Dime.
en cuanto a los insertos, que es una duda que yo también tengo, en sí,
En sí, ¿no es cierto? Estamos hablando de la pronación del pie y la estamos mirando como una alteración fuera de lo fisiológico.
Sí.
Pero cuando ponemos el inserto, frenamos esa pronación que también es necesaria, ¿no es cierto?, durante la marcha. Es ahí la duda mía que yo también tengo con mis pacientes. ¿Qué va a pasar? Sobre todo en el inserto que aparentemente ya no lo va a sacar, lo va a dejar ahí por él.
Buena idea. Uno hace la idea de que tiene un pie móvil y lo deja rígido. Es decir, convierte un pie que no tiene barra en una barra externa. No. Eso ocurre con algunos insertos. Nosotros lo que estamos colocando, cuando colocábamos calcáneo stop, bloqueaba la pronación, pero no la supinación. Y los chicos caminaban así y con suerte andaban bien. En este caso, queda un remanente de movimiento. Queda ese 4, 5, 6 grados del que hablaba Mike, de que cuando nosotros apoyamos el talón en la fase de apoyo, en la fase de inicio de la marcha, tenemos que amortiguar, porque de lo contrario estamos con una roca sobre el piso, digamos, y la fuerza de gravedad no nos perdona. Exactamente. Doctor Juan Carlos, fuerte y claro. Ahí tenés el video. Te lo presta la
Sí,
Ana María.
lo voy a soltar, lo voy a soltar.
Suéltelo a Ana María.
¿Se prendió? ¿Se ha apagado esto?
Fíjate.
Hola, ahora sí. Cuando uno tiene la idea de un pie sintomático o asintomático, uno piensa en qué realmente es un pie sintomático en un paciente con pie plano. Estoy preguntando sobre específicamente cuál es la sintomatología que ustedes como especialistas ven en un pie plano sintomático, porque hay momentos en los cuales pacientes que tienen pies planos refieren a algún tipo de dolor, y lo que estoy preguntando, Mario, es cuál es la característica del dolor que ustedes ven en pacientes con pie plano.
Sin que tengan coalición tarsal.
Sí, sí, que tengan
Bien,
colisión tarsal.
perfecto. Ahí hay un dolor...
Perdóname un segundo,
Sí, sí.
porque somos claros que estamos viendo dos tipos de pacientes, los que son sintomáticos y los que son asintomáticos.
Sí.
En los que son
Sintomático.
sintomáticos,
Y que el síntoma es el dolor.
¿y qué es el dolor?
Y que no tiene coalición tarsal.
¿Cuál es la característica del dolor?
Bien, perfecto. Excelente. El dolor a nivel de la pantorrilla que sufren los chicos, que nosotros le llamamos dolor de crecimiento, no sé si ustedes también, y en la zona anterior de la tibia, es dolor que la madre a la noche tiene que masajear, porque dice que me duele, y lo masajea con alguna crema. Algunos le ponen alcohol y emborrachan a los chicos, porque entra por la piel. Pero ese es uno de los síntomas de dolor. El dolor a nivel de la parte
convexa del pie cuando apoya, también, en los pies planos, graves, gravísimos, aparte de que se ven. Ese es el síntoma, que no es un síntoma claro, y acuerdo con ustedes que no siendo un síntoma claro, nos cuesta tomar la decisión de decirle, che, te tenemos que operar. Te devuelvo la pregunta, ¿qué síntoma o qué tipo de dolor vos ves o sentís o te cuentan que un chico con un genovalgo de 11 años o 12 años tiene y vos estás pensando en operarlo? ¿Qué tipo de dolor tiene? No pain, no tiene dolor. Yo por eso digo, sin ánimo de discutir en vano, cuando hay alguien que tiene bien plantadas las cosas, como en el caso de la gente que hace mucha ortopedia infantil y hace solo ortopedia infantil, y tiene un concepto, está bien, nadie quiere convencer a nadie. Solamente exponemos lo que uno piensa desde el otro lado. Y esto con Hypercure y antes también, ¿eh? Antes también. No sé si respondo tu pregunta.
Sí, no, digamos que el punto es tratar de puntualizar un poco más sobre la sintomatología precisamente del pie plano, que para todos decimos, él es un pie sintomático. ¿Qué realmente es un pie sintomático? Porque tenemos pacientes que tienen pie plano, caminan, desarrollan algún tipo de dolor que es inespecífico completamente. Como dijiste, puede ser en cualquier localización. Entonces la pregunta era, ¿cuál es el síntoma al que ustedes más le dan valor dentro del pie plano para decir esto es ocasionado por dolor del pie plano?
¿Cuándo vamos a terminar con esta discusión?
Nunca.
No. Este debate va a terminar un día, porque cuando yo empecé a hablar, dije que el problema del pie plano es que era un término antiguo, era un término estático, y hoy el movimiento, lo dinámico, prevalece para todo. Entonces, cuando yo tenga un examen complementario, ¿qué es un examen complementario? Complementa la consulta o complementa el diagnóstico. Que sea dinámico y que me diga objetivamente, este chico va a tener problemas versus este que no lo va a tener, allí se va a terminar el debate. ¿Cuál va a ser ese estudio? ¿Cuándo?
El laboratorio de marcha.
Perfecto. Ya está. Pero lo que pasa es que para el laboratorio de marcha, en esta parte del río, ¿cómo se llama?
¿De ahí para abajo?
De ahí para abajo es imposible. ¿Ok? Digo imposible, porque en todos lados tienen laboratorio de marcha. Hay gente que maneja muy bien el laboratorio de marcha y no solamente sirve para pacientes como los que tratábamos yo y trata usted hoy, doctora, sino también sirve para los deportistas. Si yo sé que el que tiene un retropié pronado me está cambiando ese avance sinusoidal del centro de gravedad y me lo está ampliando al doble, yo sé que ese tipo tiene mayor gasto de energía y que desde el punto de vista de la actividad física va a ser un problema. Entonces, falta eso objetivo desde el punto de vista dinámico. Después discutimos más, nos sentamos a tomar unos vinos chilenos y ya. Que son mejores que los argentinos, estoy acá, gracias.
Sí,
Bien.